Hi everyone, it's Sue again, and again, I'm hoping this will be a short lecture. You can just look at PowerPoints if you prefer, rather than listen to me talk on, because I've really tried to include what I think are the most important points, and this is very straightforward. We're looking at nursing care during pregnancy, and it really is the focus on nursing care. And I know you know this, but just so that you feel confident that you know what I believe that you know, let's all make sure we're on the same page. So let's talk about this over the next 15 or so minutes. Let's hope. So start with understanding what is the perinatal period. And that's that period while you're pregnant and before you give birth. And there's a huge amount of not only physiological change, and we talked about that in that A&P of pregnancy lecture, but also that psychological preparation for birth and parenthood as you move through your pregnancy and approach the period of delivery. And this is a really important opportunity for nurses to work with the entire family, and also to work with the interprofessional healthcare team to really make a difference in the health, not only of the mom and the baby, but the family health. And it's important we look at this from a family perspective. It's important to recognize that that women, not only who are experiencing difficulty, but women who are in perfect health, wonderfully healthy, and adapting to their pregnancy really well, seek care and guidance throughout that pregnancy, that monitoring is really critical. And we're very fortunate in Canada, where healthcare is considered a right, not a privilege. And we have healthcare coverage for all citizens, landed immigrants and refugees, that we're able to make sure that the cost of healthcare is not a consideration. But we do still have to continue to disseminate that information about how important routine care is throughout a pregnancy. And the focus typically in this period is health promotion, right? So there are times when we have to focus on acute interventions when we have complications in pregnancy, but otherwise we want to focus on health promotion for the mom-to-be, the fetus or the child-to-be, the infant-to-be, and the family. Okay, pregnancy, and this was in the modules I know you saw. Again, we know it spans 9 calendar months or 10 lunar months. So we have lunar month is 28 days, a total of 40 weeks, anytime between the end of week 37 so beginning of week 38 and end of week 42 is within term. After 42, it's post-term, and before that, it's preterm. There's 3 trimesters. Gosh, this is so basic, right? You guys all know it. Weeks 1 through 13 are trimester 1, weeks 14 through 26, trimester 2, and weeks 27 to term, trimester 3. We know how to look at the estimated date of birth. This is a good process to know, procedure to know for the NCLEX, and so it might be a good procedure to know for me. It's so straightforward. None of the formulas are infallible. The best way to confirm the estimated date of birth would be by ultrasound, and typically that's what happens now is moms are given their first ultrasound early in their pregnancy, but the traditional way to do this was using Nagel's rule. And in using that rule, we calculated a couple of ways. You look at the first day of their last period, you subtract 3 months from the first day of their last period, and then you add 7 days plus a year. So let's say the first day of their last period was June 1st or June 30th. Then we would subtract 3 months. So June 30th, we would go to May 30th. We'd go to April 30th. We'd go to March 30th. We'd add 7 days. So April 6th, and then we'd add a year. And so you go to the next year. Alternatively, you can add 7 days to their last menstrual period and count forward by 9 months. Either way you do it, right? So you're using the same formula. Most women give birth between 7 days before and 7 days after their estimated date of delivery. So we're going to talk about adaptation to pregnancy, and again, not just physiological adaptation, but maternal adaptation and adaptation within the whole family unit. So for maternal adaptation, it's really important. This is a huge change in your life, and there's the notion of how accepting that pregnancy impacts the quality of your experience through that pregnancy. Some pregnancies are planned, some are not planned, some are hard. It's a hard battle to get there. Some it's less of a hard battle. Each person has their own story. They also have their own story of coming to accept that change in their life, whether it's with jubilation, whether it's with trepidation, and whether it's with some resistance. And for us, it's not to judge that response, but really to work with the client to understand how they're experiencing that. Role transition is huge with pregnancy, right? Understanding that they will be moving from being a single person in the world, maybe being a partner in a relationship, maybe not, being a worker, being all kinds of other things, being, you know, let's say a daughter, a sister, an aunt, all kinds of other roles, but to move to that maternal role, moving to the role of a mother and adjusting to what that means within their own life. Reordering personal relationships is really critical. Understanding priorities, what matters more, how time will be spent, where supports can be found, things like that. Developing that relationship with that fetus that they're carrying. And that's really critical to understand that emotional attachment happens not just at the moment of birth, but emotional attachment happens throughout the process of those 9 months of pregnancy. And then finally, it's important to have a plan for childbirth, a mental plan, sometimes a written plan, but also just even that emotional preparation for what that childbirth experience will be like, and then moving on. The same thing with paternal adaptation. The accepting pregnancy. What does that pregnancy mean to the father's life? Or even if we were going to talk, there's paternal adaptation, but there's also partner adaptation. Often we have what I might call non-traditional couples, but it's not really fair to use that word because what is traditional anymore? But so we may have couples where there are 2 moms in a family, 2 dads in a family, all kinds of different permutations. But this idea, accepting the pregnancy, whether they are carrying the pregnancy or not, identifying with their role. So in this case, it might be a father role, it might be a second mom role, even though you're not carrying the fetus. There might be 2 dads, they're both accepting that father role while a surrogate is carrying their baby. Again, we're coming to this reordering of personal relationships. What matters? Where are your supports? How is your time going to be spent? Does that family unit become tighter and closer, or does it expand so that we have much more a broader family involvement? Each family unit or each person makes that decision about what is going to suit them best. And so our job is not to dictate, but our job would be just to explore with them. Where are their supports? How are they feeling? What do they imagine their life might be like? And again, establishing a relationship with the fetus, whether you're carrying or not, really preparing for that, the role of parent and what that will look like, begins with that child attachment right while that fetus is developing. It's important in the same way that we help siblings throughout the course of the pregnancy become prepared for how things will change. In particular, we know that we often see regression with siblings as a new baby is brought into the family, and it can be quite disruptive. So important that we don't bring about a whole lot of new changes as a new baby is about to come and really change their world. So for example, if you're going to have to use the crib for a second baby, you would want to move the first child out of the crib a fair bit before the arrival of the new baby, if that's possible, so that it doesn't seem as though the new baby is taking over the siblings' things and the siblings' routine. As it is, routine will be upset. As it is, the mom may feel, or the primary caregiver may feel a little inaccessible to the sibling, especially during those first early weeks. So it's important that you recognize that and prepare for that. Same thing with grandparent adaptation. There are many different roles, many different people involved in the life of that developing baby, and it's important that everyone begin that preparation process. So our goal, again, we talk about promoting health and promoting well-being. We're going to foster that safe and satisfying birth experience, and that means planning, understanding what a person needs. Are they hoping to have a natural birth and a drug-free birth? Are they hoping to have an epidural and have as little trauma as possible? Are they hoping, with a history of a C-section, to do a vaginal delivery? All kinds of things. That idea of a person mentally and physically preparing for birth is really critical. We want to look at self-care and how a person can manage their life to be the most well they can be through their pregnancy, and preventive care. And we'll talk about a few things that are really important there. And that we get adequate prenatal care. This is even more significant around the world where we look at economic class and finances. But even in Canada, we see that there is a difference where women of middle or higher economic socioeconomic status seek out more prenatal care, more extensive prenatal care than women of lower socioeconomic status. So what are some of the barriers to prenatal care? I'm not sure, again, if any of you have had children or have know people who've had children. We know that it's kind of not a crisis, it's a dilemma in Canada right now, that there are inadequate numbers of obstetricians to provide care. So some of the changes that have been made in the healthcare sector to respond to that, first of all, we have nurse midwives, and many people are very happy with that experience of delivery with a nurse midwife. Or with a midwife, sorry, and that creates a broader spectrum of opportunities or options for the family in terms of what they may seek for healthcare. Additionally, women now are referred to their obstetrician much later than they used to be. So their family doctor will typically follow pregnancy with the mom early up until even 20 weeks when they are referred to their obstetrician. Sometimes there are some procedures or facilities that a mom may not want to go to. Some early in pregnancy, if you're doing a dating ultrasound or just an early check with an ultrasound, it may be a transvaginal ultrasound. Some people may not like that. They feel uncomfortable or embarrassed. So it's really important to talk about what are the benefits of that and why you might be doing that, maybe with some early symptoms, early bleeding, or even just to date. Sometimes it's hard, we just assume that because our healthcare doesn't cost us specifically, that everyone can go. But for many people, that means taking a day off work, having to travel, having to make childcare accommodations and things like that. So it's not always convenient. It can be far. When we live in a large area of urban facilities, it's much more accessible. But when we live in remote areas, much more remote areas, it can be much more difficult to make your way to the facility that you want to go to for checkups, for testing and other things. Again, if I drive or if I have great bus service, it may be easier to get to my appointments than if I'm living, let's say, in a remote area and I also may not have my own vehicle. Service can be broken down. So that fragmentation means that we have different resources and different services provided in different places. So it's not a one-stop shop for everything you need. And that can become problematic, again, when it's hard to make appointments. Inadequate finances, again, so it's not the healthcare per se that we're paying for, but it is all of those associated things. I may have to try to get a babysitter for my other kids. I may have to pay for transportation to get to a facility. I may have to take a day off work, which could be problematic, and other things. And also, finally, this idea of really helping to promote amongst the population how important prenatal care is. So some personal attitudes may impact how important someone believes prenatal care is and how early prenatal care needs to start. Really important that we know home visiting by nurses during pregnancy has shown to have very excellent outcomes, right? So not just expecting a pregnant mom to go to the doctor's office, go to the hospital, go to a clinic, but rather actually having nurses go and see the mom in their home. You get to do a home assessment and start to begin some teaching that happens within the home. A person is much more comfortable typically within their home, and you have a greater opportunity to visit when it's most convenient. However, it is contrary to what we're seeing in our current environment, right? We see fewer and fewer visits to women who are low risk for complications, and really only have those visits mostly for women who are at high risk. So hypertension and other kinds of complications, maybe type 1 diabetic, other complications, I'm gestational diabetic or a type 1 diabetic whose blood sugars are not as well controlled as they could be. They may have a home visit, whereas a healthy prenatal visit typically is not happening in the home anymore. It's unfortunate because we have really good evidence that says that's an excellent way to develop a relationship with that the pregnant mom, and also to really do some excellent teaching. So what happens at the initial visit or interview, and you would have seen this on your prenatal assessment sim. So we have that basic interview, and we find out why the person is here. What are they seeking care for? We talk about the current pregnancy. We talk about their past history in relation to childbearing and the reproductive system. Talk about health history in general. Do they have any health conditions? Do any health conditions run in their family? This is important that we begin this discussion of nutrition right away. More and more we know that there's a current challenges with increased prevalence of eating disorders. Eating disorders in pregnancy can be very difficult, and it's important that we actually raise that. And as much as we go to universal screening in other areas, such as in violence or use of opioids, it's also important to be able to ask that question. I work with a lot of women who have disordered eating or challenges with their eating process, and I'm wondering if that might be something you experience. Simple, not emotionally charged, just a question that you can ask, and that helps to move along that dialogue. And finally, we want to ask about history of drug use and include herbal preparations, which can have an impact on pregnancy. Let's carry on. We're going to talk about family history. What does your family unit look like and other things, but also are there medical conditions we worry about? We talk about their occupation, their social history, their what their life looks like. If there's been any physical or sexual abuse in their own lives, and if that's something that may be triggered through this pregnancy, that's a very common experience for people who have in particular suffered sexual trauma. And we do that head-to-toe review of systems. In that initial visit, we're also going to do a physical exam, right? So we've asked them about the head-to-toe issues. Do you have any heart issues? Do you have any issues with your breathing, things like that? But we also do a physical exam to get all of our physical findings. And we do some lab tests. We probably do routine tests, but in addition, we're going to screen for STIs. And we also would do routinely now HIV testing. So really important that we move through that. And after that initial visit, we're going to go through our follow-up visits. And there is typically for a well pregnancy, there is a staged process. Once you start going for your visits, it often moves through, monthly for the first 2 trimesters. You may move in the 3rd trimester to every 2 weeks. And then for the last month or so, weekly visits. And in all of those visits, again, we're going to have that basic interview, and we don't have to go into as much detail. We have the basic family history, medical history, all of that stuff, but really making sure we check in, we know where the mom is at, what's going on in her life, what's new, how she's coping with things, how she's feeling about her changing body is really critical, and if she's experiencing any new symptoms. We also do our own physical exam, again, perfect head-to-toe physical exam, and we're going to do that fetal assessment. And in that fetal assessment, we're measuring in particular fundal height. And if you remember on the A&P of pregnancy, there was that chart that shows that increasing fundal height up until I think week 36 or so. And then when you see as the lightening happens, the fundus actually moves down a little bit. So weeks 36, 37 are sort of at their peak. And then by weeks 38 to 40, that fundus moves down a little bit as the baby has moved down. So we want to measure that fundal height. We want to determine where the fundus is in relation to gestational age. And we also want to do that fetal assessment that's going to help us to understand how the baby is doing. Once we're able to auscultate a heartbeat, we'll do that. We'll typically do that with a Doppler. And you're going to use those Leopold's maneuvers. And do you remember that was on your simulation as well? You're going to do those Leopold maneuvers to find out where the baby is located, to be able to find the best place to assess the heartbeat and go through that system as well. Again, continuing on with follow-up visits, when we look at the fetal assessment, we're going to go through a process that's developmentally tied. So for example, now in Canada, we have a schedule that helps us to determine if there's a higher risk for fetal abnormalities. So we do that multiple marker or triple screen blood test, and that includes blood work and ultrasounds that enable us to look at the neck folds and levels of and the blood marker that talks about the risk for fetal abnormality, in particular for spina bifida. We do all kinds of other blood tests as necessary, right? So we're going to look at other kinds of things. We're going to, again, make sure there's no STI in pregnancy. We may do group B strep, or we always will do group B strep, but we're not going to do that right till near delivery. It's very common for women to experience group B strep, and I think I gave you something to read about that. If I did not, just to recognize, group B strep is not a STI. it's a common streptococcus infection that can have a very negative effect on the newborn. The newborn can be exposed during the labor process. So so they will do a swab, vaginal rectal swab, and if a person is group B strep positive, they would receive a dose of antibiotics as they're laboring or right immediately prior to their C-section. Important to recognize, you might be group B strep positive for one pregnancy and not positive for another, or you may be group B strep positive throughout all of your pregnancies, or you may be group B strep negative throughout all your pregnancies. Also, ultrasounds are routine. Typically now we're doing an early ultrasound and then later dating ultrasounds. Early dating ultrasound, later ultrasounds would be looking at sort of a more precise examination of body parts and internal organs and looking at head size and other kinds of things. If there's a risk, it's an interesting thing on ultrasound, if there is a risk, if markers have indicated there might be a risk for any of the, for Down syndrome and other kinds of things, it's really important that when they do the ultrasound, another way to gain some insight into that would be through looking at looking at the bone structure in the face. We may see a flattened nose and greater space between eyes on an ultrasound. So it's an interesting process. Ultimately now we're moving to much more specific blood testing, and anyone over 40 or younger than that, but with high risk, typically now is doing more extensive blood testing by weeks 12 or 14 that tell you really where your risk lies. And finally, amniocentesis. Now that we've moved to a much higher level of testing, blood testing that's going to give us indicators of risk for things like Downs, it is less common that we're doing amniocentesis for that. Let's talk about a education plan. First, when we talked about nutrition, it's important to recognize that that old adage, eating for two is not accurate, but what you eat is really important, and that you're eating a highly nutritious food, and that you also manage some of the symptoms like nausea through eating. Whether you eat, sometimes people in old wives' tales are actually often quite accurate in these situations. If you're going to, if you're experiencing a lot of morning sickness, you may find that eating some crackers before you even get out of bed is helpful, things like that. And most people find their own most helpful ways. Important that though we make sure that in terms of nutrition, that our mom-to-be has adequate finances to be able to buy the food that is going to be most nutritious, and also that they're taking a prenatal vitamin prior to pregnancy and even in pregnancy. We know that folic acid is going to be really critical, but also other vitamins. Looking at personal hygiene, making sure that they are able to keep themselves clean and what that might mean, and if they need any support through that. Prevention of urinary tract infections, very common in pregnancy, UTIs, and so we want to help them to recognize the importance to empty their bladder frequently and practice good hygiene. Kegel exercises can be started in pregnancy, and those Kegel exercises where you localize your muscles and squeeze and hold and then let go, and you can do them anywhere you're at. When you're driving your car at a stoplight is something we often tell moms who are driving, because that gives you about 30 seconds to do your series of them. I'm just going to go off track here for 1 second and say, as much as we have always advocated Kegel exercises, there is a new kind of physiotherapist that focuses specifically on pelvic floor physiotherapy. And just an interesting aside, I don't know, again, if any of you had it, if any of you know of anyone who had it, that in France, they think it's kind of barbaric that so many North American women end up with some levels of incontinence following pregnancy and into their later years. Because in France, every single woman following childbirth is given the opportunity to have 5 sessions of this pelvic floor physiotherapy, and they don't have that level of incontinence. So in Canada, you see this growing very significantly, physiotherapists that are specialized in this area, and they actually help to increase the tone so that you have much more control of your bladder. It's important that we start talking about preparation for breastfeeding if a mom is going to breastfeed. And again, I'm going to go offside for a second here and say, for many, many years, we have used that adage, breast is best. And there's some emerging evidence about what that does to women who either can't breastfeed or who in the end, for whatever reason, choose not to breastfeed. There's some good research that talks about the shame and the disappointment that women feel in not being able to breastfeed, and how they often feel like a failure, feel that they don't want to tell anybody, feel that they're being judged, and other things. We do know that breast milk has a lot of nutrition that is really important. But we also know that formula has a lot of nutrition that is really important. So while we know encouraging breastfeeding for moms is really something that in terms of health promotion is good for moms, is good for babies. But in moving, I just want to raise a possibility. I don't want to offend anybody. In moving the adage from breast is best to fed is best, is there an opportunity to help moms who might otherwise experience these really negative consequences when they're unable to or choose not to breastfeed, so that they don't feel so socially isolated? And often that social isolation and that feeling of shame leads to maternal-child bonding issues. And that's what we really want to prevent. So I'm just planting that seed for you, that although we know breastfeeding is best, not everybody is either able to because of their own, because of their physiology and other things, because of the choices they make in their life, how their life works, and a whole bunch of other reasons. So it's important that we really don't set someone up for those personal feelings. And then finally, dental health. Who would have thought dental health would be so important? Remember in the AMP lecture, we talked just a little bit about that, how you can get, your gums can get quite spongy and you can have some gum bleeding. And that bacteria that grow in your mouth can be quite devastating. They can cause all kinds of problems, cardiac problems, other things, and also for the fetus. So dental health, keeping up with those appointments, making sure you see your dentist, making sure you have any work done that needs to be done. Let's go good. We're going to talk about changes. This is where the discussions again happen about the changes in the mom and the changes in the baby. So physical activity, lots of people are very physical. They may ask questions, can they keep jogging? What kind of exercise is healthy? Things like that. We're going to talk to them a little bit about posture and body mechanics. Remember that baby is in front and it changes the center of gravity. So we're going to work with that. We're going to talk about having to rest and relax, for the mom, taking time for herself. I always think it's so highly adaptive that the mom is so tired in the first 3 months, not because you want to be tired, but because it forces the mom often to rest more in a way where they need to rest more. Finally, it's important to look at employment, how that works, what the conditions for our employment, how they are planning to move through the pregnancy and employment. But just talk about basic things like clothing, or how, what might be most comfortable and how they move through that. And then also what travel is like, when you can travel. Typically in the last month pre-delivery, a mom would not be booking travel, but otherwise what that looks like for the mom. Finally, we're going to talk about, again, medications and herbal preparations. What are they taking? If they're up to date on all their immunizations, if they're using any alcohol, if they're smoking, what their caffeine intake is, and if they're using any drugs. Changes in their body, those normal discomforts, maybe back pain as their ligaments loosen, it may be related to that. Talking about potential complications and how to recognize them. So if they have any, let's say, vaginal bleeding or spotting, if they're starting to have labor, things like that. And again, recognizing the difference between preterm labor and Braxton Hicks. We talked about that in the last lecture, can be hard. So we really want to advise them, if they can't determine which it is, to go and seek help. Okay. Preterm labor, here we go. You look at the abdomen where the cramping can be at the bottom. You can have a backache. Often there is that pelvic pressure, right? So we're the cardinal signs that maybe that backache, lower cramps, that high up in the abdomen, and then that pelvic pressure. We're going to talk about their sex life. Some people are uncomfortable talking about their sex life, but it's important to give them permission. Make sure that they recognize that it's a perfectly healthy, and there's no contraindication to that unless you're in a situation where someone may have bleeding or other kinds of things, and those would be specific, right? Also, make sure they know where there is misinformation, where they've heard things that are not, may not be evidence-based, right? So opening up that discussion. And also looking at what kinds of alternate behaviors they could take part in. And I'm not going to go into detail with that. But that is, you can look into that further. I'm not going to ask you specific questions on a test, but changes in position, changes in activities, all kinds of things. Also providing psychosocial support for the mom. Looking at culture is really important, right? So culture is important in every aspect of our lives. But if we look at pregnancy, there's a real influence of culture and tradition here. We want to look at emotional response to pregnancy and self-care and what that means for a pregnant mom in her own life. That idea of physical activity and rest within a cultural norm for pregnancy, sexual activity as well. We talked about that a second ago, and also nutrition. There's a typo here. We know that there's some age differences in who is most likely to receive the best prenatal care. So adolescents are much less likely than older women to receive adequate prenatal care. And women older than 35, women who've had many, more than one pregnancy, or women who have never been pregnant before are much more likely to receive more care. Now let's talk about for a minute multi-fetal pregnancy, right? Twins, triplets, other things. Often result in prematurity, right? As they grow, there becomes less and less space, often stimulates early labor. Rupture of the membranes is also common before term. It's interesting in monozygotic twins, so twins that form when you have one fertilized egg that actually splits into two and then continues to develop, not dizygotic, so that's two separate eggs that were fertilized. But when you have that monozygotic originating from one egg, there's a much higher incidence of congenital malformation. Multifetal pregnancy is probably increased by history of dizygotic twins. So when you're ovulating, you're releasing more than one egg. The use of fertility drugs, we know for sure. Rapid uterine growth for the weeks of gestation, right? So we see that rapid uterine growth. That's more like, that tells us about the likelihood of more than one fetus. When we see that when we're palpating, doing those Leopold's maneuvers, there's more small parts or more large parts than expected, we're likely to determine that there might be an extra pregnancy in there, an extra fetus. When we hear more than one heartbeat, and again, when we're auscultating for fetal heartbeat, we are also holding the mom's radial pulse typically, so we make sure that we're not palpating both the swoosh through the placenta or through some other vessels around there, but we're actually hearing two fetal hearts, or more than one fetal electrocardiographic tracing. But most often, multiple pregnancies are diagnosed through ultrasound. Remember, we're having those ultrasounds much earlier. Additionally, those HCG levels, when you're doing an early pregnancy testing, may be very high. Prenatal care for women with multiple pregnancies includes really important notices in sort of patterns of care, how they're caring for themselves, and what kind of care they require from the system. We observe for the amount of weight they're gaining, both for themselves, carrying those two developing fetuses, but also because there may be a higher risk for hypertension and increase in fluid that's associated with that. And we're also going to watch for nutritional intake. Keeping in mind that large belly, particularly when you even move beyond twins to triplets and multiple pregnancies, that uterine distension with that real movement of that center of gravity can lead to severe backache. Often women with twins are wearing a brace that goes around, a support that goes around their back and under their uterus to take some of that weight off. So keeping in mind, when you've got a multiple pregnancy, there's a lot of stress associated with it. I remember thinking before I ever had any children, I would take a litter. I would be happy with 1, 2, 3, 4, 5, 6, 7, anything, right? Because I so desperately wanted my children. After I had one, a singleton, I just thought, oh my gosh, how could I have handled more than this? It's really an interesting phenomenon, and I take my hat off to anyone who has had multiple pregnancy and has raised multiples, because boy, oh boy, that's a lot of work. But strain often happens in ways you might not have thought about. So finances are huge, doubling up everything, looking after two of everything. Space is huge. Even having one new baby in your house can be full and overflowing. Having two is a lot. Workload is massive. That idea that you're breastfeeding to, if you're breastfeeding, or you're feeding to, or you're changing to, or you're doing all of that, is really kind of overwhelming, I think, in lots of situations. Although, again, we have an incredible capacity for coping, and both the mom and the family can really respond to the situation in lots of different ways, very positive ways, and also some ways that struggle. So it's important that we assess for that. Lifestyle changes can be necessary, and there's lots of twinning or multiples organizations that support people who experience multiple multifetal pregnancies. When we're talking about childbirth education and care providers, still many women having infants go to see a physician, either a family physician, but more likely now an OB, to deliver their infant. We can seek care through a midwife. Midwives still typically deliver in the hospital, but they can also deliver at home. And a doula. Now, a doula doesn't deliver a baby alone, but a doula is a support person who's with the laboring mom throughout the process, will become acquainted and develop a relationship prior to the process, but is like an advocate, helping the mom to cope, helping the process through delivery, but is not the medical practitioner. Lots of places we can have our baby. We can have a typical labor and delivery setting where we go through labor, there's the delivery room, we go to a recovery room, and then beyond that to a postpartum room for recovery, and that becomes the room that we typically stay in. We can go to a birth center where we have all of that in one place. We have a room that looks much more like a home setting. You may have a large bath to sit in, all kinds of things that make it feel much less medicalized, or even a home birth. And it's important that we recognize if someone is choosing to have a home birth, that we have to put safety at the forefront. So what kinds of things are necessary in order to have a safe home birth, and who will be there, and how is that process unfolding effectively? It's important that throughout this perinatal period, we're really supporting the woman and her family to make good decisions for their own lives about pregnancy, birth, and then that early period of parenthood. It's important that we support that childbirth experience, and we engage in health promoting education throughout. Relationship-informed care that really focuses on what the needs of that person are from their perspective, and also bringing forth what we know from the evidence about changes that occur, necessary information, and necessary process. Types of things we talk about in those childbirth education programs are those things we've just talked about here. Physical and emotional changes, early introduction of the idea of breastfeeding, and again, I'm going to say it's a balanced approach that we need. Really important that we focus on nutrition. I hope you've had an opportunity to talk about that a little bit in your nutrition course. What work looks like now, and what the future might look like. Their labor and birth plan, how they imagine that would unfold, and what their thoughts are about pain management through the process. Beginning the conversation about becoming a parent and that life transition, and allowing people to go away and think about it, but always leaving the door open for future discussion. And then newborn care. How do you take care of a newborn? I think lots of people, before they have had a baby, have never changed a diaper, or don't know the rules around all kinds of care. Whether a baby sleeps on their back, on their side, on their stomach. Things have changed over the years. Whether you use baby powder or not. You remember that was a very common thing many years ago. We don't use that anymore. Like, just so many little things that have changed so much. Even cord care has changed so much over the years. You're supposed to use alcohol wipes and all other things that you used to use? No, it's just regular care, keep it clean and dry. Even bathing is a really important one. I know many of you know more about this than me, but we used to do daily baths with babies, and then it moved on. And now the suggestion is that we try to wait as long as we can after birth before we do the first baby bath. So often moms are not seeing that demo and learning how to do baby bath in hospital. They may just learn about it, but not actually do it on their baby, because they would like us to wait as long as we can, even up to a week or even 10 days after delivery before that first bath, because that fatty layer on their skin is actually helpful for the baby to prevent infection, and it's important to keep it on if we can. Different facilities are still in the midst of either adopting or not adopting that, but there is good evidence. Important that we give the mom and the family really good advice around how you might want to develop a birth plan. We don't give them advice about what the birth plan looks like, but how they might want to go about and develop it. And really they focus on pain management as a part of that, and other kinds of techniques they might want to use. Relaxation, imagery and visualization, doing that conscious breathing approach, whether they want to do biofeedback, massage, all kinds of other things that may help through the laboring process. C-sections in Canada and around the world really are something of concern for us, so that we know still in Canada, the stats tell us a lot of infants are born by C-section, roughly 25 to 30%. That number changes a little bit from time to time, but still we have a lot of C-sections. They are much on the decline, although what I would say is through COVID, there seems to be an increase in C-sections because of just the complications of bringing a mom in to have her baby in the midst of all of this. So it's interesting. We'll look at the stats when the dust clears. And again, number of C-sections varies by the provider, the care setting, all kinds of things. And you can either have a planned C-section. There may be a reason why you know you're going to have a C-section, or it can be an emergency C-section. We know that following a previous C-section, depending on the reason you had that C-section, if the baby was breech, for example, and the doctor decided in consultation with the mom that they would do a C-section rather than attempt to do delivery, the next pregnancy could be they could allow the mom to do what's called a VBAC, or an attempt of vaginal delivery following a C-section. Sometimes the mom wants to, sometimes the mom doesn't. What we know about C-sections, there's 3 circumstances in which you can have a C-section. You can have a C-section that's an emergency. You can have a C-section that's planned, or you can ultimately have a C-section when you have previously had a C-section, tried a VBAC and it hasn't worked, and gone to a C-section. So there's those kind of 3 conditions. We know that most moms will tell us the best experience under those conditions is a planned C-section. An emergency C-section can be emotionally hard, but also moms kind of gone through that difficult laboring process for a long time and then had the C-section. So you have the negative consequences of both. And it just is, can be a harder recovery. Oh my gosh, here we are, we're at the end. Great to talk to you. I hope this has been helpful, and I will talk to you all soon.